So as Christina was just mentioning, the idea of today's presentation is to explain you a little bit what are the elements that might make this activity different and more successful in some places of the world and not in others. So first of all, just to let you know, I suppose you know that despite transplantation is already consolidated as a very successful therapy, we are only doing 10% of the global needs. And this is mainly because of the fact that most of these organs will come from deceased organ donation, and the countries that do not have this deceased organ donation will do living kidney and liver transplantation. So as Christina just mentioned, it is true, Spain has been leading deceased organ donation for the last 30 years. Then it is followed by the US, which has a totally different model. I will try to explain you the differences. But then I think what is really interesting is to see those countries that are in green, that are Portugal, Czech Republic, Belgium, Italy, Croatia, that are over 30 donors per million population. And some of them didn't start DCD, no, like in Germany. Why it is important to highlight those countries? First of all, because it is important to note that the country's economic wealth is not directly associated to a highest deceased organ donation rate, as you can see here. No, just not to mention Germany, I will mention Japan, that is here. Okay, so Japan is leading many other healthcare fields, but in donation they are really at the bottom. So I think that that's interesting. So there are other factors that might explain what is the secret of this leading model. No. So, and I'm not talking only about Spain, I'm talking about these other countries like Portugal, Croatia, Slovenia that have put in place, or Italy, that have put in place very similar elements in the system. The most important element is the professionalization of the activity. What do I mean with that? I mean that we need to have trained specialists in organ donation. And those specialists needs to be working and dedicated to that. It can be part-time or full-time, but someone has to lead that inside the hospital. This is you can only do that through a continuous education program. No, it's not only one shot that will change the situation. You need to have a plan, a training plan, and this will make the difference. By having those professionals inside the hospital that are dedicated and that have been trained on organ donation, then you'll be able to change the culture inside the hospital. We usually think of changing the culture among our citizens, but the first thing to do is inside the hospital. If all our colleagues in the hospital, including nurses, social assistants, administrative people, do not understand, for instance, the brain death concept, they will be the ones explaining to the public misconceptions. So it is really important to work first in the hospital, and then you'll be able to transfer this knowledge and change of attitudes outside the hospital. A continuous quality plan is very important because it helps to measure, but also to improve the outcomes and the processes. So it has to be totally embedded in the system, in the program. We need, of course, institutional support. We need a legal framework. We need to have a well-set inter-hospital network. All these things happen in Germany, of course. You need to have a national competent authority that in Spain is called the Organ National Transplantation, the National Transplantation Organization. In Germany is the DSO. And then in Spain, what we do, and the same happens in Italy, in Portugal, in Croatia, is that we don't have a specific budget on public awareness. So we have around 1 million of euros for professional training, but we have no specific budget for awareness. Why? Because at the end, the ones working in the hospital, the patients' associations will be doing this work of public awareness. And the activity outcomes themselves will also give very good arguments for our citizens to understand what's going on, and also to have a transparent and an equitable system. And finally, very important is the innovation. If you don't have specialists working every day in organ donation, it will be very difficult to be innovative. And innovation has to be also as quality totally included in the program, in the whole donation and transplantation program. So in Spain, for instance, there have been a lot of innovations. I will go through them later on, that have changed the things. Without these innovations, we would remain with 30 donors per million population. The Spanish system itself has been, recently there has been a publication in Lancet explaining what are the main points, and at the end, what they say is that you need legislation, innovation, and organization, no? But this professionalization is also included in this article. So the message is that it has nothing to do with luck or with things that we cannot change. It has to do first on skills and on very pragmatic and measurable actions that you might do. Another important concept is that transplantation changes somehow the paradigm in medicine, because, of course, the society is not only the beneficiary, but it's also the one that will procure the organs. No, at some point they are the ones providing organs as donors. So society is part of our field of organ donation and transplantation. But then the second important thing is that usually the governments and the systems put a lot of energy, money, and so on in the transplantation side, while abandoning somehow the donation part. And the clue is to put at the same level the surgeons and the intensive care doctors in charge of donation. So if in the hospital there is an equivalent in between donation and transplantation, and they are not working in the same department, this will be a huge leverage for the system and for the donation and transplantation program. Usually when a country starts doing transplantation, the ones that are worried about not having donors are the transplant teams, nephrologists, surgeons. This is good for the beginning because they are the ones that will be pushing and who have the contacts to change the things. But at the end, these transplant teams cannot take charge of the organ donation. They need to delegate this activity to another group of professionals. What they did in the USA, and that has inspired a lot the German system, is to externalize the organ procurement outside the hospital. In the US is different because the OPOs, the organ procurement organizations, are private organizations, usually non-for-profit, that have a big area under, big or small area under their services. So they provide their donation services to an area. So the hospital only has the responsibility to call the OPO when a potential donor might appear. Okay. What we did in Spain is much cheaper. Okay. And for our public system, it was impossible to create something external to take care of the donation. Our teams in the hospitals would have not understood that. And on the second hand, it is, as I said, much cheaper. Okay, because if you have to create a totally new organization, this is another another category of budget that you have. So what we did in Spain is to create inside the hospital a specific organ donation unit that is independent from the transplant teams, that is independent from the ICU teams and the emergency teams, and which unique objective is to have organ donors and tissue also donation. Okay? The people that are working in this organ donation unit are always doctors, so it's always led by a doctor. This doctor is usually an intensive care doctor that can be still working in the ICU and part-time working as key donation person. But in some cases you have, and this unit can be composed by this unique doctor or by a team. And these teams can be very different depending on the hospitals. So you might have hospitals in Spain with 5 doctors full-time and 5 nurses full-time, or you can have another team with 2 doctors part-time and 5 nurses full-time. It depends a lot on the activity and the culture of the hospital. So this ICU doctor focused in organ donation, part-time or full-time, and very important, this unit and this person depend directly from the medical director of the hospital or from the general management. This independency and this power is absolutely important because it is the way to make sure that we have the push and the recognition of the high power, and it's part of the strategy of the hospital. So those units have clinical activities to be done, but they also have to work on quality. So in our centers, we do audits. In between the different centers, so we have internal audits that are done from the donation unit of the hospital, and then the different teams will move from one hospital to another one to do external audits. And another important thing is that these organ donation units, most of them are doing awareness campaigns, not campaigns, but awareness activities outside the hospital in their community. Another strength of the system is to involve from the very beginning all the healthcare that will be directly or indirectly involved in organ donation. And by working together, the professional associations of intensive care or emergency, we have been able to move forward and to make those professionals that organ donation is also part of their job. So in some protocols that were very much involved, like what we called intensive care oriented to organ donation, which means to accept a patient, to admit a patient in the intensive care with the unique purpose of organ donation, this couldn't have been done without first working with the intensive care society that has created its own protocol for that. independently from the donation units or together with the donation units. I'm very much in the conceptual part because I think that it's really important and words are important. So in Spain, but not only in Spain, in Portugal, in Croatia, in Italy, we understand organ donation as a fundamental right and responsibility of the citizens. So that's why we feel comfortable, we totally feel comfortable by putting every measure we can put in place to make sure that this person can fulfill his right of becoming a donor. And the other important concept is that donation is part of the end of life care. It's not something added, it's not something coming from outside. It's just something natural that is inside the process. So if this is well understood and integrated by all healthcare professionals in the hospital, everybody will understand that an organ donation request, a family interview for donation, is never an assault, is never something that you can say it's not the moment. It is part of the process. Organ donation is part of the end of life care. And the other thing is that for those families that have been able to take a decision regarding organ donation and they have accepted, we have seen that this is contributing to a positive grief. Let's move now to data and innovation actions or programs that have been put in place. So, of course, I'm sorry, but I have to talk about donors after cardiocirculatory death. Why? Because this year, last year in 2025, it has been the first year that in Spain we have had more donors after cardiocirculatory death than donors after brain death. And this proportion and this tendency is not only happening in Spain. Here you can see the United States. Here you can see that Portugal, that is only doing DCD type 2, so uncontrolled DCD, and now they are going to start with controlled DCD, they are already doing 5% of their donations in DCD. Czech Republic also will now start doing more. Belgium is also exceeding the number of DCD compared with DBD, etc., etc., etc. So Spain has also become the country with more donors after cardiocirculatory death in the world, followed by US, Belgium, the Netherlands, and Switzerland. Of course, the more donors you have, the more transplants you do, but the countries that cannot do or that they don't have a very high deceased organ donation system, they will be doing more living donation. And this is quite, let's say, we need to take care of that and so on, because most of these countries are countries in where you have big economical disbalance among the citizens. So it is important to make sure that this living donation is not done through coercion or through commercialism, okay? And of course, for Spain, this is one opportunity of improvement. And this is one of the programs that are part of the new strategic plan for the next 10 years to improve living donation. This is what has happened regarding deceased donation in Spain. So for a long time, we believed that we couldn't go over 35 donors per million population, which was already good. But then in 2015, we started DCD type 3, because DCD type 2 was something that was done several years already ago. But then this was a really great increase that COVID stopped, but now we are back and at the top, no, and increasing. Last year we did just a little bit less than 2024 with 51.9 donors per million population. So in these last 10 years, we have increased 50% of our deceased donation activity. The more donors we have, the more transplants we do. We are also the country with more transplants per million population. And DCD has not changed that tendency, because thanks to the use of NRP in DCD, we are now able to do thoracoabdominal NRP in DCD type 3, and that transforms those donors into multi-organ donors. This increase also has been important in the last years thanks to the DCD. Is the disease donation activity homogeneous all over Spain? Well, not really. We have regions that are doing even more. They are doing over 100 donors per million population. But if you look at the numbers, there is no region doing less than 40 donors per million population. So even though there is, well, Balearic Islands, no, last year went a little bit down, but it is, I think it is important, no? The tendency is very high. And then in those regions, it has a sense, no, and a reason why they are having more. Those are low populated regions with a unique big ICU hospital center that will centralize all potential cases, no? So very less potential donors will be lost. So in Spain, we have 187 donor hospitals, which means that any hospital with an ICU, it doesn't matter if it's public or private, will have someone in charge of organ donation. And we have 47 transplant hospitals, and 10 of them are pediatric. It is a lot of transplant hospitals. If we had to start from scratch, I think it would be much more efficient to have less transplant hospitals. But once you have a transplant program, it's very difficult to take it out. Our donors are not ideal donors. We are the country with the oldest donors in the world. Okay? So, and I, even if it's an old, I don't have this one updated, but look, we always know, this is one thing that when I am in Germany, sometimes we discuss about it, but in Germany, your donors are not as old as our donors, okay? So this is something that also has to do with the fact that we have more donors, because we really push the envelope. We really are forcing the limits, no? Somehow. Well, DCD has increased 48% of the transplants. I already said that. And then another innovation that was not done by the donation units, but by the society and the government, is that in 2021, the euthanasia legislation was put in place, and parallelly, we created a protocol that to give the opportunity to any person that decided to go through euthanasia to become a donor. It was not easy at the beginning because the donor specialists were not used to talk directly with someone that will become a donor and that will die. But it has become something more and more current, no, in our activity. So you can see that thanks to euthanasia patients that decided to donate their organs, we were able to transplant in those last 5 years 643 643 recipients. Only, and that's also important, only 14% of the people who ask for euthanasia becomes donors. Some because of the medical contraindications, and also because if you are asking for donation, you cannot die at home. And this is a limitation that for the moment we are not able to solve. Pediatric transplantation in Spain is also a priority. So that means that our waiting list is usually 1-2 patients, because any pediatric donor will go to the pediatric, and now any adult liver of a small donor will go to the pediatric, but also we will do split. So in the last 6 years, we have stopped doing living liver donation because we have enough livers to do splits for our children. As I said before, living kidney transplantation is low performing and we could improve. Catalonia, the Barcelona region, is the region with more living donation, and it has to do with the hospital culture. Our teams are very proactive in living kidney transplantation. And another very important point is tissue donation. If you have a unit in every hospital in charge of donation, it makes a lot of sense that any person who does in the hospital that could become a cornea donor, a vessel donor, a skin donor, could become a tissue donor. So that's why, and it is true that it is in Catalonia in where we have a more developed tissue donation system, we are having per year around 2,000 donors, no? Sorry, I didn't translate this part in Catalan, but those are the tissue donors we had in 2025. So there was an increase of tissue donors in respect of the last year, and then an increase of tissue available for our citizens. So as I said before, training is a pillar. It's a pillar because this training has to be continuous and has to be approached in 3 different levels. So we have the professional training for hospitals, for hospital healthcare professionals and managers, because we need to convince and to make the managers of the hospital understand how important transplantation is, and then how donation should be a priority for the hospitals. It is also a must to have academic training at the university level, training postgraduate and graduate students. And then also, instead of doing awareness campaigns, what we do is to train the non-healthcare professionals, because, as I said before, in transplantation, our citizens are not only the beneficiary, but they are also the providers of organs. So by training influential groups of the society, we can multiply and change the attitudes regarding organ donation and transplantation. So as Frau Schleicher just said before, we have been training professionals in organ donation and transplantation since 1991 through a project called TPM, Transplant Procurement Management, that started to homogenize practices in Spain, but very fast we moved to the international. And since then, we've trained over 20,000 participants from 113 countries. This is not only a wow because we've been in many places, but this is really enriching, because anywhere you go, you will learn new ways of doing the thing. So it's really a knowledge exchange. It's not a one direction in training. So I think that this is really important. And then, as Christina just mentioned before, because this training was getting proportions that were over what was expected, and that we moved from the hospital to the university. And then when we started doing cooperation, the university told us this is not a university mission. This is why we created this non-for-profit organization based in Barcelona. It's a foundation. And the aim of DTI is to support professionals, countries, hospitals on the development of sustainable and self-sufficient transplantation programs. And we do that through training, through cooperation, and also through research. So the objective really is to create these experts in this field, and basically from the critical care, from neurological units, from emergency departments, and transplantation and tissue banking. So having the whole picture. Is training efficient? Well, it's very complicated to evaluate the efficiency and the impact of training, but in a very basic way, we will put the parallel, in between the people trained, that are in bars in different countries with the disease donation evolution. Here is the Spanish data. Then we are working with Italy since 1993. And here you can see in Italy also, all intensive care doctors are trained in organ donation. And then this has an effect on organ donation activity. Portugal, very successful model too. Slovenia and Croatia. So in these cases, it's the Ministry of Health who hires DTI to do the training of their intensive care and emergency doctors and specialized nurses in organ donation. We have similar pictures in Thailand, in Iran, that nowadays is having 13 donors per million population. In China, remember that in China, since 2015, they didn't really start having donors like us. It was another totally different system before. And since then, they've changed that. And we have also been very much involved in training. So we've trained in China over almost 2,000 intensive care doctors and nurses. So those were basically the elements that I wanted to share with you. But don't forget that it's not only a matter of knowledge and experience, but it's a matter of passion. And why do I say that? Because if the people that are working in organ donation do not really understand and do not really feel that this is an opportunity for them to have a professional career, to develop research, to do education, to have sometimes a higher status in the hospital, if this doesn't happen, you will don't have the motivation. And without motivation, without passion, this is not gonna happen. So thank you very much for your attention, and I'm ready to answer any question.